Hi, my name is Aaron Fisher. I am an internal medicine resident at the Methodist Dallas Medical Center. I will be presenting a case report on Guillaine-Barré syndrome following an extended spectrum beta-lactamase Escherichia coli urinary tract infection. Guillaine-Barré syndrome, or GBS, is a post-infection inflammatory polyradicular neuropathy characterized by ascending flaccid paralysis and areflexia. The microorganism Campylobacter jejuni is most commonly associated with GBS, comprising about 30% of cases. Our patient was a 69-year-old female with a past medical history of metastatic breast cancer, status post-treatment with chemotherapy and radiation therapy. She presented from an outpatient rehabilitation unit with persistent lower extremity weakness. Approximately 1 month prior, she was diagnosed with an ESBL Escherichia coli urinary tract infection at an outside hospital. During the hospitalization, her course was complicated by the onset of progressively worsening bilateral lower extremity weakness and paresthesias that promptly occurred after the onset of her urinary tract infection. At that time, the complication was believed to be secondary to being in a state of sepsis. However, she experienced little to no improvement in her strength despite being compliant with the prescribed antibiotics. On this admission, on physical examination, the patient had normal vital signs and was noted to be alert and oriented. She had significantly decreased strength of her lower extremities with diminished patellar and Achilles reflexes bilaterally. Sensation was preserved. On lab studies, it showed that she had a non-significant thyroid studies, normal vitamin levels, SPEP and UPEP were negative. Paraneoplastic studies were obtained that included neuronal antibody, CV2.1 IgG antibody, Purkinje cell antibody, neuronal nuclear IgG antibodies were all obtained and were all negative. Cranial and spinal cord imaging were negative for acute findings that would explain her symptoms. Neurology and neurosurgery were consulted, who concluded that no neurosurgical interventions were needed. No anatomical or paraneoplastic etiology was deemed to be the cause of her symptoms. EEG was negative, and electromyography and nerve conduction velocity studies were obtained, showing no motor response in her lower extremities. The patient was treated with a 5-day course of intravenous immunoglobulin for the diagnosis of GBS. This resulted in prompt resolution of her lower extremity weakness. In the literature, Campylobacter infections are known to induce a physiological response where IgA or IgG antibodies are produced against the bacterial cell wall. In some cases, these antibodies pathologically cross-react with various epitopes of human nerve cell gangliosides. This cross-reactivity is the mechanism by which GBS develops. The process of molecular mimicry between human nerve gangliosides and the lipooligosaccharides found on the cell wall surface of Campylobacter jejuni are what make possible the autoimmune response of the produced antibodies that were initially made to combat the original infection. E. coli contains lipopolysaccharide on its outer capsule that can induce production of positive IgG antibodies against gangliosides on neurons. This can also induce GBS. Of the few documented cases of E. coli UTIs preceding acute motor neuronal neuropathy, most patients had positive antibodies to the GM1 and GD1A gangliosides specifically. Our patient met criteria of GBS with a clinical picture of rapidly developing paraparesis, diminished lower bilateral extremity reflexes, and nerve conduction studies showing no response in her lower extremities bilaterally. Her positive response to IVIG also supports the diagnosis as well. Workup for C. jejuni, neurologically anatomical etiologies, epileptic etiologies, or paraneoplastic causes of her symptoms were negative. The resolution of our patient's neuropathy with 5 days of IVIG treatment can serve as a basis for treatment for future cases for this specific etiology of GBS and can inspire further studies in the future for Guillaine-Barré syndrome as it relates to ESBL E. coli urinary tract infections.